Our shared goal is to create a future where all people have clean air, clean water, and nutritious food, and where the climate has returned to a stable state. The webinar is part of a series of 4 webinars for credit that the consortium is offering for during the month of September. After today, the final webinar is next week on the 25th. Before we get started, some housekeeping items. Please place your questions into the question and answer space. We'll pose them after the speakers have finished speaking. CME credit is available for this webinar. The link to the CME questions and certificate will be available in 3 ways. In the chat immediately after the presentations and before questions. It will be posted on our website under Learn CME or in an email that you will receive. Presentations will be available on the consortium website. An email will arrive after the webinar with links to the presentations, a tape of the webinar, and any other CME questions and certificates. I want to thank our support, Colin Ackerman, for running the Zoom today. I will go ahead and introduce our 2 phenomenal speakers for today. Dr. Cassandra Thiel is an assistant professor at New York University in the Grossman School of Medicine, the Wagner School of Public Service, and the Tandon School of Engineering. Her research utilizes life cycle assessment and principles of industrial ecology to analyze and improve the environmental performance of medical systems, hospital design, healthcare practice, and medical technologies. As a 2014 to 2015 Fulbright Nehru Academic and Professional Excellence Fellow, Dr. Thiel calculated the environmental footprint of cataract surgery at Aravind Eye Care System in southern India. She received her PhD from the University of Pittsburgh and Bachelor of Science from Michigan Technological University, both in civil engineering. Her graduate training was supported by the Mascara Center for Sustainable Innovation and a National Science Foundation Integrative Graduate Education and Research Traineeship. Our second speaker is Dr. David Chang. He's an executive committee member and past president of the American Society of Cataract and Refractive Surgery, the largest surgical subspecialty society in ophthalmology. He is a past chair of the American Academy of Ophthalmology Cataract Preferred Practice Pattern Panel, which develops the national practice guidelines for cataract surgery. Dr. Chang currently co-chairs the American Society of Cataract and Refractive Surgery Foundation with a focus on global cataract blindness, and he is the recipient of the 2019 American Academy of Ophthalmology Humanitarian Service Award. He also co-chairs the Ophthalmic Instrument Cleaning and Sterilization Joint Task Force, which developed specialty-specific instrument processing guidelines for ophthalmology. The task force recently completed a large survey on surgical waste and the carbon footprint of cataract surgery. A graduate of Harvard College and Harvard Medical School, Dr. Chang is a clinical professor of ophthalmology at the University of California, San Francisco, and in private practice. In 2006, Dr. Chang became only the 3rd ophthalmologist to ever receive the Charlotte Bear Award, which annually honors the outstanding clinical faculty member at the University of California, San Francisco Medical School. He was also twice voted the 5th most influential ophthalmologist in the world by the International Readership of the Ophthalmologists, and he has delivered more than 40 named lectures. Without further ado, please proceed.
So let me get my slides up here. Hopefully the slideshow will work. All right, is that looking good? Everyone can hear me and see me? All right, those are the phrases of 2020, I guess. All right, so thank you so much for having us. I'm gonna kick off today by talking a little bit about sustainability in general and then some of the work that we've done in ophthalmology specifically, and then I'll hand it over to David to talk a little bit more about the survey that we ran and some of the results of that survey. So some of you may be new to sustainability. I know quite a few of you are probably already familiar with these concepts, but I wanted to give you a moment to just think about what the word sustainability means. You know, at its core, it's just the ability to be sustained. But of course, when we're talking about it in this context, it's more than just, you know, a program that can keep going. Usually the way that we think about it, at least academically, is kind of this triple bottom line concept, which could also be called the 3 Ps or the 3 Es, so people, profit, planet. The economic side of this, the profit or the cost side, is something that we're all really familiar with, right? If it goes bankrupt, it's not sustainable. But for something to be truly sustainable, it has to be sustainable in all 3 of these realms. So on the people side, that can mean the equity aspects. For healthcare, it could be quality or access issues. Basically, it has to be good for employees, for patients, kind of fulfilling. It's a little bit harder to measure things in that realm, but that is truly important. And then the third pillar is this environmental side or the planetary side. And basically a lot of human systems right now are consuming more than the planet can actually provide us in our short timescales. And so this is one realm that we're really trying to work on, particularly in healthcare. And my lab, my research is really focused on this environmental side. There are tools and technologies we have available to be able to measure the environmental impact. The major one is what we call life cycle assessment. I'm not going to go into too much detail, but basically this is a tool to quantify the environmental emissions from a product or process throughout that product's life cycle. So you can think about, a life cycle of a product. You start out with raw material extraction. We need these raw ingredients. So we take those from the earth. We ship them to a manufacturing facility, probably multiple manufacturing facilities around the world, and we produce products out of those things. We ship them again to the places where they'll be used. In our case, it's usually a hospital, right? We're looking at healthcare services. There may be some reuse that is conducted. So we might sterilize items. We might just straight up reuse them, but ultimately it'll end up being disposed. For healthcare, that's usually a landfill or incinerator. And what you'll notice about our product life cycles, human-made product life cycles, is they're not very cyclical. And this is one of the major challenges with human-made systems, is that we're very linear, which is not natural, right? If you think about things in nature, there's never a true waste product, right? Something will always use the waste from something else. But that's not the case with a lot of human-made things. But life cycle assessment allows us to look at this whole life cycle and then see the inputs and the outputs to the system. So we need energy, electricity, fuel, kind of at all of these different stages, and those emit different environmental pollutants. And so life cycle assessment takes all those different environmental pollutants from across that whole life cycle and summarizes them into a single number, like a carbon footprint. And the reason we use life cycle assessment, one is because it's a very powerful quantification tool. It gives us solid numbers. So we can compare different products and say mine is greener, and it's actually greener because I have numbers to support it, right? It prevents that greenwashing that's very common in the sustainability industry. You see a lot in food products or common household products. The other thing that's really helpful is it allows you to identify parts of your system that may be underperforming environmentally. So it could be, this transportation method I've chosen has a really high carbon footprint, and there are alternatives that I can substitute that with to reduce my footprint. So we're using life cycle assessment a lot to try to figure out, what part of the system has high emissions and how can we do something about it. So to think a little bit more about healthcare and sustainability, it's unfortunately a field that's emerging, right? We haven't spent a lot of time thinking about healthcare services in terms of sustainability like we have in other industries. But we know that climate is impacting health and our ability to provide healthcare. This is an image from my home institution, NYU Langone Health, during Hurricane Sandy. So we had to shut down in the middle of the hurricane. We lost our backup generators, we lost all power, and a hospital without power not only does not have lights or elevators, it doesn't have ventilation. We don't have life support systems in place, right? This is a tragedy. And unfortunately, we're not the only health system dealing with these kinds of issues. The Camp Fires closed, I believe, 3 hospitals, and the fires now out west have also shut down a variety of hospitals and healthcare facilities. And these are all things that will get worse with climate change. So storms and fires, medical facilities are starting to become aware of this particular issue. It's not just our ability to provide care on the whole, we also have to look at our supply chain. So this is a little news clip from Hurricane Maria, which hit Puerto Rico a few years ago and really shut down a lot of manufacturing of medical products. So we had supply shortages, which impacted our ability to provide care as well. And this will also become more common. We could talk about the COVID pandemic and its effect on PPE supply chains. There are some environmental relationships with the COVID pandemic, but we know that our supply chains are fairly vulnerable right now, and we're just not prepared to deal with a lot of these challenges. Beyond that, healthcare itself actually does have a footprint. So we're not alone in being impacted by climate change, we impact climate. And if we're thinking about that triple bottom line, we impact all three of these things, right? So the larger statistics are that US healthcare generates about 10% of the US's total greenhouse gas emissions. That is a very large number. Basically, if US healthcare were itself a country, if you pulled it out and made it its own country, it'd be the 13th largest emitter in the world. We consume a lot of supplies, a lot of resources, energy, all kinds of things, and all of that has a carbon footprint that affects our planet. And unfortunately, healthcare has a really large footprint. And these can also be tracked back to public health impacts then. You can see other healthcare sectors are not immune to this as well. I think the global average is about 4.5% of global emissions are coming from global healthcare services. And so the US is disproportionately high, which is not surprising if you think about our spending on healthcare here relative to other countries. So those emissions end up impacting human health as well. This is a nice big table, but the main takeaway, if you go down this impact category list on the left, there's a category called PM, that's particulate matter. The very top one is global warming, just to give you some perspective there. But you can see for particulate matter, if you go all the way over to the right, the percent of national, where almost 9% of particulate pollutants are coming from the healthcare industry across total particulate emissions in the US. And that amounts to 435,000 disability adjusted life years. So we can actually quantify the lost life, if you will, due to the pollution that's caused from healthcare. So this is kind of a tragedy. Unfortunately, there are other issues that are a little bit more direct than environmental pollutants. So this was a long study in the NHS that was looking at reusable surgical tools, and they discovered labor violations in the supply chain, in this case, child labor, but this is also, unfortunately, very common within all supply chains and hard to monitor. It's definitely an equity issue. And on the equity issue for cost, this is not a great slide to display this, but we all know in the US that there are many people who cannot afford healthcare and will not seek healthcare because of that issue. And part of the reason they can't afford it is because it is very expensive. And as we'll learn, kind of going through the rest of these slides, some of the expenses are completely unnecessary, right? We're not even using some of the supplies we're throwing away, or we're very wasteful in general, and this does add to our costs. This is kind of a sadder story about this more direct environmental and equity interaction. But I think it was 2 summers ago now, there was a company called Sterigenics north of Chicago that was closed down for their emissions of ethylene oxide. ETO is a sterilizing agent that's used on all single-use disposable supplies that are sterilized. So anything coming into the operating room is typically sterilized using ethylene oxide. The gas is cancer-causing. We know it's a carcinogen. And this particular company, of course, they have EPA limits how much you can emit into the environment from your company, and they were within their legal limits, but they did find higher cancer rates in the community where this facility was located. And because of that, they closed down the plant, even though it was within its legal regulatory limits for emissions. So the community did band together to force this plant to close, but they did not change the systemic issue in that all of our surgical supplies are being sterilized this way. And this is one of those very sad ironies in that it's much more directly due to healthcare that some people ended up dying of cancer or having to be treated for cancer. So this is the cyclical, horrible side of healthcare that we're trying to address. So how exactly are we trying to do this? Well, it's a systems issue, right? It's not simple as anything in healthcare is. So if you think about all the things that go into healthcare, these all have an impact. I think very much in this physical realm, right? So the lighting, the electricity, the disposable goods, the reusable goods, all these supplies that are needed to actually provide care. But there's so many other layers to this that you have to consider when you're looking at changing, right? It's how we pay for healthcare, how we are reimbursed for healthcare services. It's the contracts we make with other companies, local training habits, regulations and policies. There's all these things that are tangled up together that impact how we provide care. So data is really important, and that's where the life cycle assessment comes in. So we already saw this, but just a little reminder, we can use life cycle assessment to look at healthcare practices to try to analyze the impact. This is an overwhelming graph from one of my very first studies at the University of Pittsburgh under the supervision of Dr. Melissa Billick and Dr. Millie Woods. We looked at hysterectomies, 4 different approaches, so abdominal, vaginal, laparoscopic, robotic, and we did a life cycle assessment. This is what the results of a life cycle assessment look like. So you can see the 4 different groupings of hysterectomy, and then each grouping is a different type of emission. So you have ozone depletion, greenhouse gases, smog, acidification, eutrophication, kind of going from left to right there on the bottom. A bunch of different emissions that do impact health of humans, but in kind of different categories. So you can think emissions to air, emissions to water, emissions to soil. And what we found here in this study was really that the production of single-use materials was driving a lot of the emissions for US hysterectomies. And also what you'll notice is that the laparoscopic and robotic surgeries tend to have a higher footprint than the abdominal and vaginal surgeries. And this is interesting because we have higher tech we're going towards. We were able to, fortunately, transcribe that graph into something that's a little bit more palatable for most people. Unfortunately, engineers love very complicated graphs. But here you can see, basically, it's advocating for that reduce, reuse, recycle model in that order, right? So if we reuse or reduce our medical instrumentation, we could minimize the carbon footprint of laparoscopic hysterectomy by almost half. If we change the anesthesia we're using, we could reduce the carbon footprint by 1/3. If we start reusing things like reprocessing single-use devices, that could reduce our footprint by 10%. Whereas you'll notice far on the right there, recycling really only changed the emissions footprint by 1%. So this thing that we spend a lot of effort on may not be worth it in the end, that we should really focus on reducing, then reusing, then recycling. So that's all a lot of background. We're 10 minutes into this, and now I can talk about ophthalmology. Why do we want to talk about ophthalmology? Well, it's a really cool field. First off, they do a lot of surgeries, and surgeries are very resource intensive and wasteful, as it turns out. This is a little clip from one of my favorite studies out of California. It was a neurosurgical department that looked at all of their unused supplies. And if they somehow managed to not throw away things that they were not using, they could save $3 million just in their department. 13% of their supply costs were just wasted supplies. So we know that surgeries are very wasteful. And beyond that, ophthalmology is a very large specialty. Basically, if you live long enough, you'll need cataract surgeries. It's one of the most performed procedures worldwide. In the US, we spend about $6.8 billion annually on cataract surgeries, and half of that is from Medicare. So cataract surgeries alone account for 12% of Medicare's budget. So this is huge. In addition, we have more people on the planet. They're living to longer ages, so there will be more people who need cataract surgeries. And we're trying to expand capacity globally so that more people can access cataract surgeries, because it's a pretty fast procedure and life-changing, where you can go from blind to seeing again with very little complication rates. So it's a really interesting place to start because it has such a wide reach. So what do we know about it? Well, shortly after we had done the work on hysterectomy, there was this paper published by Dan Morris and colleagues out of the UK, looking at the carbon footprint of cataract surgery. So the main form of cataract surgery that's used globally, at least in developed countries, is called phacoemulsification. For those of you who are not familiar, we'll call it phaco. And they found that a single phaco emits about 180 kilos of CO2. That's like a British person living for a week. And this is in a surgery that could last maybe 30 minutes or so, I guess up to an hour. There's a lot of variability there. And unsurprisingly, they found that the procurement of supplies, single-use supplies, was a large portion of their footprint, right? We'd seen the same thing in hysterectomy. And this got me wondering about what healthcare looks like in a place where they're not using so many single-use supplies. Where would that be? And this question led me to the path of a Fulbright Nehru Fellowship to look at surgeries at a place called Aravind Eye Care System, which is in southern India. It's a remarkable place. You should probably look into it outside of this presentation. If you're interested in hospital management and efficiency, they've done a lot of really interesting work. There's a TED Talk on them as well. But this is their operating room. You can see it's a little bit different from ours in the US. Typically, one surgeon has 2 beds they're operating on. So one bed is being prepped while the other is in surgery. And then when that surgery is done, they flip the bed over, flip the equipment over to the second bed. And the first patient is let out and a third patient is brought in for that bed. And so they just go back and forth between the 2 beds. The other thing you'll notice is that many of the supplies are reusable. This has shifted a little bit with COVID, but they are trying to be as efficient as possible with their resources. So they have cloth caps, face masks, gowns, drapes. The only things that are not reusable would be a face gown for the patient that goes over the actual surgical site. The patient booties, most of them are actually barefoot in here, but they have the booties, and the intraocular lens, what they're actually putting into the eye. And this usually is the stage where a lot of people start, having doubts. How effective is this surgery really? And this is the beautiful thing that actually Dr. Chang has worked quite a bit on, is that ARVIN has excellent outcomes. So we don't necessarily keep track of a lot of these nationally in the US, but here you can see the comparison between ARVIN's outcomes and the US's. Particularly that last one, rates of endophthalmitis, is a big one. That's an eye infection that can occur after surgeries. You'll see the ARVIN's rates are much lower. So they're a very effective system. They're doing this surgery well, but they're also doing it for low resources. The slide keeps popping up in here. We did some life cycle assessments and we had to basically observe all of these cases at ARVIN, and we started weighing the waste. It's a good way to start out with life cycle assessment. You need to know what's being used in this process so you can model that whole life cycle. So this is what we did. We started weighing things, looking at all the resources that are consumed. This is a good visual for ARVIN and just the difference between what they're doing compared to the US. So this is 1 phaco removal in the US, the garbage from that. And on the right is 93 phacos from ARVIN. So you can get a big visual difference of the change in resource consumption between the 2 sites. For the carbon footprint then, we compared this with the UK-based study, and you can see it's a big difference in their footprint. So the UK's emissions are like driving a car 500 kilometers, and ARVIN's are like driving a car 25 kilometers. Essentially, for providing the same surgery, you could provide, I think it's almost 20 surgeries for the same environmental cost, if you will, as one in the UK. So this is one of the big things that we learned, is that you can actually do these surgeries very well, very high quality, but with a much lower emissions profile. So some of the things that ARVIN does, one is they pay a lot of attention to their physical layout. They set up their surgeries kind of like an assembly line. The founding doctor for ARVIN actually had the thought, if McDonald's can make hamburgers so cheap for everyone, why can't we make cataract surgery cheap for everyone? And part of that is setting it up like an assembly line. So the surgeons are never waiting. The patients are always flowing through this system. And part of that has to do with how they physically laid out the space. They also engage in what's called task shifting. So they have mid-level ophthalmic professionals who do all the pre and post-op work, so the surgeon can focus only on cut to close. And that makes them able to see many more patients throughout the day. They standardize everything in the process. So the pathway steps for the patient, the instrumentation trays are all standardized, and pretty much everything is used in those trays. There's never, whole segments of trays that are just there and need to be cleaned between cases even though they weren't used. And most of the surgeons follow a very standardized surgical approach. And that really helps reduce some of this unnecessary waste. Beyond that, they are focused on how they can maximize reuse, because that reduces the cost so that their patients can afford this care. Finally, they're very attuned to safety, because it doesn't make sense for them to provide care if it's not going to actually help people. And that's really key. So we'd also come back to the US, of course, and we're looking at cataract surgeries here. And one of the major complaints we heard was about the amount of drugs that were wasted. Here you can see the supply spending between different US hospitals, and it's variable. It changes from location to location. The drugs in particular were really variable between sites. And here you can see ARVIN's supply prices are, of course, much lower than many of these US locations. So we wanted to set up a little study to look at the waste of surgical drugs because this seemed to be a contentious issue for a lot of our surgeons. And so in this study, published in JAMA Ophthalmology last year, we looked at 4 different facilities in the northeastern US and found that eye drops in particular had a large percentage that were wasted. These usually come in 5 to 15 ml bottles, and there's a few drops put in a patient's eye in each surgery, and we have to throw them away between each case, even if they're labeled as multi-dose and even if they're antibiotics that the patient would be using later on after the surgery. So there's a lot of unnecessary waste here. We converted that wastage into financial costs, and 2 of the sites were throwing away essentially over $190,000 worth of drugs each year. That would pay for an additional 53 surgeries at market rate. So that's just a lot of wasted money. And of course, we're producing these drugs that has a carbon footprint. So even if we're not using them, we are creating emissions. And at the 2 sites that were wasting the most, they were essentially wasting 105,000 metric tons of CO2. That's like driving a car between Alaska and Florida 51,000 times. So there's a lot of waste just in the pharmaceuticals from cataract surgery. So one of the things I wanted to really point out is that if you're looking at how to make your surgeries more efficient, low resource settings are a great place to start because they can't afford to waste supplies the way that we do. So they'll have already come up with really great innovative approaches for reducing that resource use. I'm going to jump ahead a little bit, but or I'll try to go fast through these slides so David has enough time to talk too. But we're engaging more globally in ophthalmology, right? Because Arvin's not the only location that's doing really interesting things. So I have project partners in the UK. We've developed an app and a website that's allowing us to audit surgical services. It's actually completed by surgeons or surgical teams where they can measure their own productivity cost and carbon emissions and waste generation, particularly for cataract surgeries. We're trying to expand it to other specialties and other procedures, but this has been a great way to engage clinicians and to help us figure out what's happening out there in all these different global sites. Can we develop best practices from this global arena? So that's been pretty exciting. We also are seeing an emergence of climate action working groups. Both the Royal College of Ophthalmologists in the UK and the International Agency for Prevention of Blindness has engaged in these topics and is trying to support their membership in becoming greener and more sustainable. So this is where I will hand it over to David to talk about what we're doing more here in the US. I'll run a quick thank you just to our sponsors, NSF and the IAPB, as well as the many people I work with on this project. So David, take it away.
Thank you. So if you'll need to unshare your screen, great. And thanks for a fantastic overview, Cassie, and that's a ton of information in a short time. So what kind of lessons do we have for other specialties specifically? You know, the last 12 years has seen an unbelievable rise in the intrusion of regulations into our operating rooms, whether you operated an ASC or a hospital. And for us, you know, we will just seemingly out of the blue, here's some new regulation that's come from some advisory group. And what we've had to do, we've combined the American Association of Cataract Surgery, the American Academy of Ophthalmology, and our ASC subspecialty society. And we've had to join together to create a task force literally to defend longstanding practices that we have used in cataract surgery against sort of an onslaught of new regulations that are eminence-based rather than evidence-based, meaning there's really not based on problems, but rather because some expert says this is how to do it. And I co-chair this task force. So here's an example. In 2014, all of a sudden, CMS came out with a policy that you can't use the shorter cycle for sterilization. It's got to be a fully wrapped cycle, which is not the way we do it in ophthalmology. So we had to do our own studies to show why this was for our specialty safer. This was the specialty-specific guidelines from cataract surgery that was mentioned earlier. And when I was chair of that panel, I editorialized and said that the cost of cataract surgery is so high that we really have to evaluate what practices, especially new ones, are being imposed on us with data. Well, here is one such data point, and this is from Aravind, and it is their infectious rate. And we did this study really to compare the prophylaxis with or without intraocular moxifloxacin. But it gave us this data that you can see here, which is their current rate with phaco is 1 per 10,000. And we have good data in the US because we have a national registry, and it's 4 per 10,000. So despite the fact that they're reusing everything, their infection rate is lower. Well, how could that be? Well, it's complicated. We don't have the ability, we don't have a commercially approved intraocular antibiotic, a long story. And that's why half of American surgeons don't use this. And that's really what lowered the rate at Aravind. But what Cassie just showed you is their carbon footprint is a fifth, 5% of ours. And yet our infection rate is 4 times as high as theirs. And so you have to reach the conclusion that there's really an unproven benefit in terms of single use for preventing infection, and that this contributes to a lot of excessive surgical waste. So we did a survey for these 4 societies. This is the Canadian Ophthalmology Society. This was just published as a special report 2 months ago, and I also have an editorial in press that was invited on this topic. So we got cataract surgeons and their nurses. We had 1,500 respondents, 1,300 completed this very long survey, and more than 1,000 MDs. And 9 out of 10 are concerned about global warming. Strong consensus that we are excessively wasteful. Only 5% felt that we're doing okay. It was mostly Americans. 6 out of 10 were ASCs. It was a good distribution in terms of age and surgical volume. And if you look at what is driving waste, well, single-use items that are wastefully packaged, facility policies, regulatory agencies that limit our ability to use our discretion to reuse things is a major factor. I would say prior to 12 years ago, we would do things in the operating room like we do in our offices. It might be off-label, but certainly no one has a greater stake in avoiding infection than the surgeons and nurses. But this all changed, whereas now we have to literally follow these instructions for use, and the CMS regulators will come in. It's unannounced. It's like a drug raid. They come in and tell everybody not to, tell anybody or do anything. And they'll pull out the instructions, and if it says do not reuse and you're reusing it, they cite you, and you have 2 weeks to correct this or be shut down. And it's very zero tolerance and punitive. We cannot practice off-label. Other drivers, surgeon preference? No, not a big one. Patient preference? No, not at all a big one. Manufacturers are definitely contributing in terms of these opinions. Yes, we need to do recycling. They should consider carbon footprint in their design. But really, we need more reusable options. And their instructions should give us the discretion. They need to protect themselves liability-wise, but we need some discretion on what can be reused and when. Same thing with regulatory bodies in terms of allowing discretion. And people felt that the medical society should advocate for reducing the carbon footprint. So this was getting into reusing either topical or intraocular drugs in multiple patients or supply items. So Cassie mentioned the waste from not being able to reuse topical drops in the pre or post-op area. Intraocular, almost as much of a consensus that these can be used at sterile on more than one patient. And then supply items, the things like the phaco tips, where sometimes the manufacturer will say you can only use it once. And yet the exact same phaco tip, another manufacturer will allow you to use it 25 to 50 times. No discretion. And these are just examples of the per case types of things that we have to mostly use single use that we have a strong consensus from surgeons that they're willing to reuse them. This is, again, not controversial. Why can't we send the bottle home with the patient after we use it to put a drop of antibiotic after surgery? This was that issue of using the shorter cycle. And then there's growing impetus for doing 2 surgeries at the same time, which would reduce carbon footprint. This is eliminating the patient's drape, not having the patient change into a hospital gown. And this is using the same surgical mask all day. Remember, the survey was completed before COVID. We have a lot of people, 2/3 are interested in not even changing surgical gowns between case, less so with changing gloves. People still want to change gloves. Now, what would increase your willingness to reuse things? Well, cost, of course, is big, but it's actually not as big as the motivation in terms of waste reduction and efficiency, another factor. What would decrease it? Infection, certainly, but you see that even higher than infection was malpractice liability. What are the primary drivers for single-use instruments? Well, sure, performance and safety. Patient preference, no. So this is a little bit of this is counter to what many manufacturers are saying, that patients really want to be the only person that instrument is used on. The real drivers, though, are not efficiency, but down here, the manufacturers striving to reduce liability. Certainly profit is an incentive, and easier regulatory pathway. But when you ask a surgeon if an instrument was of equal cost and functionality, 10 times more prefer the reusable version than the disposable version. Reprocessing of single-use instruments and supplies is something that we don't have in ophthalmology, but this shows there's willingness to look at, to consider this. This means it's FDA approved for single use, but you send it to a reprocessor that's also FDA approved, and they'll repackage it and sell it back to you at a discounted price. It's kind of like getting a used car from a dealer with a new car warranty. So what our survey showed that, yes, there was strong consensus about excessive trash. We need more options to either reuse things or to have multi-use options. There was this preference of reusable versus disposable, which is counter, I think, to the opinions of many of the manufacturers. And then again, more discretion, and the manufacturer can allow this, as well as regulatory agencies. Where do we go from here? Our task force took this survey, and it's not scientific, but the one thing I think it does do is it presents a lot of data to the manufacturers. And so right now we have our task force has invited the 4 major surgical suppliers: Alcon, Johnson & Johnson, Zeiss, and Bausch. They've each nominated representatives to our committee, our task force. We're having our first big meeting in the first week of October. And each of these manufacturers has pledged to us to work on reducing carbon footprint. And this is very much a collaborative effort. We're really pleased with the response. And I think this is what the survey has done for us more than anything, is to focus attention on this topic. So we look forward to working with them, and hopefully this gives other specialties some ideas in terms of what can be done. And manufacturers, at least, they control their own destiny. It's going to be much harder, of course, to try to have CMS change the way they regulate things, but one step at a time. So I think this is a good time to end. So thank you for your attention. And I know we have some time for questions if there are any.
Really excellent discussion there. I have a few questions I'll start with. Feel free to post in the chat as well. But I just wanted to say, for those new to this field and interested in doing this work, how do you go about developing this climate lens that you both have, either yourself getting into the field as a scientist or as a physician, or in teaching your students to look at projects through this lens?
Cassie, why don't you start?
Sure. So for me, it's a little easier because most of my students would come in already interested in this lens, at least for students. But I really try to engage anyone, whether they're a fully trained clinician or a med student or even an engineering student. I try to get them to think about the things that they care about, right? So not everyone's going to care about carbon emissions, and that's completely fine. But clinicians may care about the health impacts of the things that they're doing, like these larger public health impacts. They may care about the money. There's a whole bunch of different things that people are concerned about that all overlap. And particularly in healthcare right now, I tend to use the word bloated, but it's so bloated that there's so many things you can do that will fix all three of these sustainability realms. So you can grab people based on their interests, right? It doesn't have to be just carbon emissions. And as I start going through this rabbit hole, they may get interested in the environmental impacts, and that's where you can supplement it with more information, right? There's a lot of things out there to do. I think we were kind of talking about this earlier. For a lot of med students or residents, they are asked to do quality improvement projects or research, and we don't know a lot about the resource use in healthcare. We don't keep track of it very well in a lot of institutions. So even something as simple as auditing the waste from whatever specialty you're working in, that is an actual contribution to your field. Just getting out a weigh scale and weighing your garbage. So there's lots of little things that can be done in this field to help engage people and get them interested.
And I would just add that education for physicians and nurses is a big part of it. I think we all inherently know that we're wasteful, but until you see data and actual numbers, it really hits you that this is really not sustainable. And, understandably, we also, have this culture, this tradition of spare no cost for safety. In the past, any attempts to say, do we really need to do this or that? Well, you're just trying to save money or make money, and you can't put a price on safety. But I think with the data now, we're really kind of looking and saying, gee, this is not sustainable, whether it's economic or environmental. But the data is important. I think one thing that will change is we now have increasingly in our specialty, and I think most, these registries. And that's what really Aravind has contributed, is strong registry data. And that's how we know what their infection rate is. And who would have predicted that with a fraction of the cost, with a footprint, 1/20th of ours, because they reuse everything, that their infection rate would be a quarter of ours. Who would have predicted that? Who would believe that without the data?
All right, we have a few more questions coming in. Can you speak to larger sustainability reporting efforts compared with all other economic sectors?
Yeah, there are, this is a tough one. We don't do a lot of reporting. There are individual hospitals that will engage in some of the common reporting metrics, like there's GRI, Global Reporting Initiative, and I think like Cleveland Clinics and Kaiser, I believe, participate in that, or some of those more UN-based reporting metrics. So some hospitals will do carbon footprinting of their systems and will report that publicly, but it's not very common yet in healthcare practice to see those kinds of things reported.
And then we have, who would you suggest be the health system admin person to first approach?
Is this asking?
If you are interested in getting involved at your own institution or healthcare system, it sounds like.
So this also depends on the healthcare system. Some systems have sustainability coordinators or some executive sustainability team members. So there may be a sustainability team you can actually join. If not, it may take a little bit more effort, but you could be the lead on your sustainability team. I've met a lot of people who are very passionate about this, and usually they're clinicians in specific specialties who really want to know more about their own specialty. So they'll lead a quality improvement project just monitoring the waste, and they'll try to connect with people like me. There's not many of us out there who will do carbon footprinting life cycle assessments of healthcare, but we exist. And certainly a lot of university systems, if you're tied to a university system, may have someone who can help with those calculations. But yeah, usually it's kind of self-directed at this stage. It's very much a ground up kind of approach. There's very few systems, I think, who have more of a top-down approach, but they do exist. So you'd have to do a little exploration, but there could be partners there. Supply chain people, I think, are also pretty fun to work with. You may have a lean management team or a value-based analysis team who could also kind of work on sustainability if it's not directly. So.
And I would say probably another place to look is your specialty societies. I mean, I think this is a big topic. It's not something one individual can necessarily do a whole thing, but I think it might require a subspecialty society engaging someone like with Cassie's expertise to do this type of assessment. And then her comment earlier about looking to resource limited settings for innovative ideas, because as you say, they can't, Aravind is such a great example. They cannot afford to waste anything. 60% of their surgeries, they do the largest surgical volume in the world. 60% of them are done for no charge. And it's all financially self-sustaining because they basically shift profit from their paying patients. So it's just a wealth of information from that one institution that we're fortunate to have in ophthalmology to give us some great innovative ideas. And it goes right down to even with COVID now, they've got some great ideas. One of the interesting things that's happening at Aravind, I'll just throw out, is that with COVID now, they can't really do some of their normal assembly line techniques. So they're actually having to sort of emulate sort of more of our systems in the US of maybe not so many people crowded into the operating room, maybe doing one patient at a time in the operating room just to get through COVID. And what they're doing, which is great, is collecting infection data now that they can compare to infection data pre-COVID when they were doing things differently. So we'll be able to sort of look at specific practices. Does having multiple people in the same operating room actually increase the infection rate? So we look forward to that data.
There are a few people interested in using the app to monitor waste, and they're asking how they can do it and determine the amount of waste produced.
Yeah, so you don't need the app to determine the amount of waste produced, because we do actually ask people when they're using the app to have a waste scale of some sort and to just weigh the garbage after every case or at the end of a set, depending on how you remove waste from your operating room. In the US, it's usually after every case. But yeah, so the app is available through efficiency.org. It's technically still in piloting or beta testing phase, so it may not be 100% awesome at this stage, but we are trying to release it to the public. Right now it's geared pretty much just for cataract surgeries. We're doing, I think, something else in ophthalmology. I can't remember which process it is. And we're also looking at kind of flipping it over, I think, for one of the orthopedic surgeries, because orthopedics is another really interesting area. But so right now it's kind of still in testing phase, but we have had about 30 sites use the app. We call it efficiency, just the name pop up. So EYE efficiency, and we're trying to expand it for other specialties because we know it's a pretty effective way to measure productivity and cost and carbon. The carbon emissions on that one, as a caveat, are not incredibly accurate because the data that we're collecting, we're trying to make simple for you to collect. And sometimes doing a life cycle assessment requires so much data. So this is kind of a higher level, gives you more of an order of magnitude for carbon emissions rather than exact details.
I would just, I'm looking at the questions also. A lot of people are looking at where do they start. I think the survey was a useful tool. Surveys, are obviously not randomized studies, but in an area like this, it's pretty important because who are you really trying to influence? We mentioned manufacturers, and so it's basically a customer research tool. I think the other is liability. So much of what we do that's wasteful is concern about liability, and it's not just the surgeon or the ASC or the hospital, but the manufacturer. And yet when you can show that 95% of people feel it's okay to reuse this or that, I think, again, I think that gives you some support in terms of you're not doing something that's crazy or way beyond the standard of care. So even though surveys for a lot of our clinical practices really aren't adequate, for something like this, I think they can actually be quite useful.
Yeah, and I would say on that note, when I talk to people who are interested in sustainability and engaging in it, I usually talk about your sphere of influence. So, you know, what you feel like you can contribute to the field. If it's just at this local level, if you're a surgeon, you can talk to your surgical team about reducing the amount of unused supplies. So that's a good way to start, just within your really smaller sphere. It doesn't have to be this high level engaging the whole industry thing. But you know, you can tell your staff basically, don't open things until I tell you to open them, or confirm with me that this is the item we need in the surgery. And then you could perhaps engage with your larger department and to talk about how do we standardize our custom packs and our trays so that things aren't being thrown out with regularity. And so you can see how this kind of broadens the sphere of influence. You can make a big difference just in your own surgeries, your own procedures, maybe in your own home institution. And then you can also look more broadly, if you're interested in it, or if you have that sphere of influence, to go with your specialty societies, or you know, a hospital at large, whatever that is. But there's lots of things you can do at all these different levels, depending on where your influence lies currently and how much energy and enthusiasm you have for the topic.
And then David asked, are there similar studies to the Aravind one showing similar results? Essentially, what other specialties or what other research have you guys come across?
I don't know in other specialties, but I think I've seen some studies from India in general, you know, in terms of basically being able to do more with less. And I do believe in other surgical fields, they've done similar things. There's some people, I know of one group that was kind of working even on a book or something that try to bring in a lot of examples specifically from India on how they are innovating in other, you know, like orthopedics and even open heart surgery. And there are quite a few studies that have shown, and often it's focused on cost, how they can do a kind of a world-class procedure at much lower cost beyond simply the labor differences. But you know, I think it requires being in that specialty and sort of, you know, looking around.
I think most of my global work has been focused on ophthalmology, so that's where I'm focused. But yeah, Dr. Chang is right that India does have a lot of really interesting examples of efficient medical care. They have really high volumes that they can work with, so it doesn't necessarily apply to rural areas. But there are interesting models. I do remember hearing of a student who was working on some projects in South America with medical tourism. So those may be industries that you kind of check out in that they are probably relatively high quality, but they're obviously much cheaper than the care we receive here in the US. So those may be interesting places to start. But you can be sure that there are, like every specialty will have a place that's doing things pretty well, but with far fewer resources.
You know, medical students are, this is a great area or project for medical students. You know, they can't do a lot clinically yet. They don't have the expertise, and yet this doesn't require clinical expertise. And actually at Stanford, which is about 5 miles away from where I practice, there are some students looking specifically at how to reduce waste in ophthalmology at the Stanford operating rooms. So it doesn't have to be some, you know, huge study. You can literally look there, but that's a great resource to think of. What a great project for a medical student.
All right. You'll see the CME link in the chat, so feel free to get that. And I just wanted to close, Dr. Chang, Dr. Thiel, thank you so much. Really great information today, a lot of interest. Just final takeaways you'd leave our participants with.
Well, we're just grateful that Cassie's been interested in ophthalmology, so please don't steal her from ophthalmology.
And I'm very happy to see all of this growth, especially in ophthalmology. It's been really exciting to see the journey. I think, you know, as Dr. Chang said, you know, we've kind of got this good upward swing, right? We started with some basic studies looking at information about infection rates and just some data on carbon footprinting and costs. And using that information, we've kind of spread the word globally and nationally. And now we're seeing this survey that's leading to some changes in policy and potentially engaging with industry to make differences, right? It's on this nice upswing, and it's really exciting to see that shift. I think it can happen in any specialty. And certainly there's lots of room for improvement in US healthcare. So stay engaged and keep trying.
All right. Thank you both again. Really excellent. So,
well, it's a lot of fun. I'm glad we can share this information.
Thank you very much.
yeah.
Be well, everybody.
Yes.
Yeah.
Take care.
Take care.